without further ado, what I really am so honored to tell you about is Miss Senda-Ajorud Driss, and she has most recently been honored a well-deserved recognition in her professorship is the highest academic honor that she has received from the Northwestern University Fine School of Medicine. And she has worked very hard with the ALS research, and we are so proud to hear her this afternoon. So, Miss Senda, please go ahead.
Hello, everybody. I am thrilled to be here and tell you quickly about myself. I was born in Tunisia, North Africa. Can you guys hear me?
Yes, yes, we
Yes.
can.
And I've been living here in the US for almost 30 years now. I joined Northwestern almost 20 years ago, and I've been taking care of ALS patients since that time, long, long time ago. Got to meet Hank and many, many other really impressive people. So I'm thrilled to be here today. I thought about preparing a presentation and go over a slide, but I thought maybe it's easier and better to just have a conversation and try and answer whatever question you guys might have. Very informal. You can shoot anything to me. If I don't know the answer, I promise I will look it up and I will send whatever response I can find. Just quickly, so we make sure everybody is on the same wavelength, let me just make sure we know what we're talking about when we say PLS. As you know, motor neuron disease or motor, or like how do we move? How do we make a gesture, right? What are the circuitry that is important for us to make a movement? If I wanted to scratch my hair, for example, I have to plan that I'm scratching my hair, and that planning phase takes into account the upper motor neuron. We call it upper because it exists in the motor strip in the brain. However, that's the planning, right? But the execution, my planning motor neuron, my upper motor neuron will speak to the motor neuron in my spinal cord. That one is connected to the muscle in my hand and will make me scratch my head. Okay. So we call motor neuron disease because the problem, the degeneration happened in the neuron or the brain cell that control movement. And as I said, we have two motor neurons that are important, the upper that is important for planning, and then the lower that is important for execution. So motor neuron diseases are spectrum of diseases, and depending on what brain cell degenerate, they could have different names. So for example, if only the upper motor neuron degenerate, we call it primary lateral sclerosis or PLS. If both the upper and the lower degenerate, we call it ALS. And if just the lower motor neuron degenerate, we call it progressive motor atrophy. So we have these names that we call, and the question that has been going around for a long time is this just one disease, or are these many, many, many diseases? And you all, if you do have PLS or upper motor neuron predominant disease, you do know that you look a little bit different from the patient who have ALS. Patient with ALS usually, when we look at the statistics, they live between 3 to 5 years. Patient with PLS have a problem with disability, may not be necessarily a problem with a lifespan. So, as you know, patients who have PLS or have degeneration of the upper motor neuron, they do progress slowly. And that's really a catch right there. That slow progression is at the same time a blessing and a curse. It is a blessing because the progression is slow, which is amazing, but it's a curse. It makes it really hard to design a clinical trial. When you do design a clinical trial, you want to see a change. And if you cannot see a change, then you won't know if your drug can help or no. So that's the difficulty. The other problem with PLS, which is a good problem to have, it's rare. So not many people have it, but that's also a curse in itself. Because it's rare, it makes it hard to study because it's difficult to have big enough number to see if there is any difference. The other problem that we have is when somebody start to have symptoms, it probably takes anywhere from 3, 4, 5, 6, I don't know, maybe 10 years to get a diagnosis. And that's a problem in itself. It takes probably at least a good 3 to 5 years to get a diagnosis. And the reason for that is, by consensus, we call patient PLS if they have no evidence of changes in that lower motor neuron on the EMG, for example, or they have no weakness that is attributable to any problem with the muscle, for example. And for that, we need to repeat that EMG. I'm sure many of you had many of these EMGs. We keep repeating them, and we want the one that we do after 3 years or 4 years from onset of symptoms to be normal or to show very, very little involvement. So we do have some challenges with this disease. It's a rare disease. It takes time to diagnose, and it does progress slowly. And that's the reason that there isn't a lot of there is no clinical trial that is available for PLS patients. The other problem is it's hard to know if we have a clinical trial and we make people better, we don't know are we making them better because we are helping the symptoms, helping the stiffness, or are we actually making them better because we are protecting those brain cells? It's very difficult to say, and we have to have a way to measure that. So the good news, in the past few years, there is a big, big interest in PLS patients. And there is a big interest to put kind of the foundation to start have ways to measure the progression, to improve the diagnosis so that we can get ready and have clinical trial. I don't know how much you guys know, but recently we were involved in a study led by Dr. Mitsumoto in Colombia that was focusing on understanding how does PLS look? How do the patient who have PLS, how are their symptoms? How do they progress? And we followed patient for a year, which may not be a long time, but at least if we have a big enough number, that'll be it give us some information. So we're very, very anxious to know the result of that study that's still ongoing. In this December, we have the motor neuron disease meeting. It's an international meeting, and there will be the third PLS symposium. And in that symposium, we're going to sit together. We're going to have researchers from all over the world, expert in ALS and PLS. We are all going to sit together and try and really push very hard. If we want to develop a clinical trial for PLS patient, how will that clinical trial look like? Who are the patients that we need to put in? How are we going to measure the change in the symptoms and so forth? So I'm very, very excited to tell you that you guys have been very patient, very, very patient, waiting, participating in what we call registry study as much as you can, but very, very frustrated because there is never clinical trial for PLS patient, unfortunately. We don't even know if the drugs that we have for ALS patient could help PLS patient even. Nobody had studied that. So I'm hoping that those things will change and we will know a little bit more. And I'm really, really very excited for the meeting this December. My role in that meeting, I'm going to be one of the panelists, and my role is to really discuss what inclusion criteria, what are the things that the patient need to have so they can be included in these studies. And I think that was my introduction. I'm gonna just take a moment here and see what kind of question you guys might have, and I'm happy to answer any question you throw at me.
Well, right now you have Jeff. Go ahead, Jeff Feen.
Oh, before you say that, I have a disclosure to make. I actually don't know anything about NU9. I don't know where it is. So if you guys have any question about NU9, I'm sorry, I don't have the answer for that. I know that the drug is being, it passed some of the safety, but I don't know if the phase 1 trial in a healthy volunteer started or no. So I don't, that hopefully is one of the question, and I don't know. I can look and ask the status of that though, and get back to you with that.
Thank you, Doctor. Jeff, you've got a comment or a question? Please go ahead.
So with ALS being upper and lower motor neuron, do you know of any ALS drugs or therapies that uh, uh, that treat the upper motor neuron? And would that be helpful to any of us?
That is a very good question that you ask. You're asking me, does the drug work differently if the upper motor neuron versus the lower motor neuron degenerate? I don't think we have a reason to think that there is a difference in the degeneration. And we think that the upper and the lower motor neuron degenerate the same way, but we're not sure about that necessarily. So when patients die and we look at the autopsy material that we have, we do a section of the brain, a lot of the neuron died already and only a few are left. And it's the same in the upper motor neuron and the lower motor neuron. So we don't think they degenerate differently, but maybe they do. The clinical trial for ALS patients are also difficult. And as you know, we don't have that many drugs available. We only have 2 so far. We actually only have 1 because the second one, Radicava, the Adore trial in Europe was negative. So we only have Riluzole available, and we don't even know exactly how Riluzole acts and how it protects, and if it does protect the lower motor neuron versus the upper motor neuron. So I don't know. It's a good question, but I don't know that we have the basis to answer it. The reason PLS patients are not enrolled in the study is because most ALS study are either a 6-month, 9-month to a year study. They're short studies. We do know that the ALS patient within 6 months usually progresses. So if a drug would be positive, it can help that progression within that time. But we do know that the PLS patient, on the other hand, may not progress within 6 months, 9 months, or even 12 months, and sometimes even longer than that. I have many patients who are very stable and have not changed in a long time. So if we're not able to see a change, the tool that we have are not good. We need to develop better tools. And that's the reason why PLS patients are not involved in the ALS study, because we don't know that they progress. They may make actually the drug look very good when it may not be. Did I answer your question?
You're on mute again, Jeff.
Yeah, I think so. Yeah, there's really no way of knowing. I'm just wondering if there's anything that we should be trying. I know that I had looked at something that what's his name? The doctor at Duke.
Yeah, Dr. Bedlock.
Yeah, I had looked at something he had posted for supplements, and I started taking some of those, thinking, well, maybe that will help. But in my progression has been really slow, and so whether that's helping or not, I don't know. But I figure, well, if I'm not using it, I'm just peeing it out. So
the other problem with PLS is we have the symptoms that are sometimes difficult. So that stiffness is a little bit like a fever. You have a bacterial infection, you have a viral infection, you have a fever, you take an ibuprofen, you help the fever. It's the same. So in PLS, we have that stiffness, the spasticity that sometimes needs to be treated, and maybe helping the spasticity may help, but are we actually going all the way to the bottom of what the problem is? It's very hard to know, because it's those 2 symptoms that go together. So sometimes you may not know. If you take baclofen and it makes your walking a little bit better, then what are we testing here? We don't know what we're testing. So that's the problem. In ALS, there are so many other things going on, so it's a little bit easier to tease out. There is a scale, it's called the PLS FRS. It's the same scale that we use for ALS, the ALS FRS. However, it has other items on it. We're working to show that this scale can change, and there is a study that showed that it does change within 6 months. So that's good. We only need a bigger number of patients to show a difference.
So
Sorry, I can't
Kenneth has a
raise my.
question. I'm sorry. Kenneth, you got a question? Go ahead, sir.
I am over 20 years in with PLS. What is the goal of the studies that you are considering?
We haven't started any study yet. The goal of the study could be to help the symptom, but it also could be to stop the progression. And why not? Maybe to reverse things. I mean, those are the things that we would like to see.
Absolutely. Jeff, you got another question or comment? Go ahead, sir. Unmute.
I do. You mentioned the PLS FRS. Is that the one that Dr. Matsumoto came up with?
Yes,
So it seems like it's got like 2 more questions than the ALS functional rating scale.
correct.
Okay, and so if we wanted to start filling that out, because I fill one out for an ALS, the ALS TDI, I fill one out for their ARC study. And it doesn't look like I've really progressed much in the last couple of years based on that scale. So I'd be interested in the PLS FRS. Is there some place we can reach that?
So yes, it needs to be validated and it will be used more widely. We've been using it in research right now. It's not as, I mean, its use has not been as disseminated as the ALS FRS. But you said you've been using the ALS FRS and you have not progressed on the ALS FRS. That's what you were saying?
Right, it's been up and down, but I've pretty much been the same.
Right.
I guess it depends on the day that I fill it out, how I'm feeling.
That is the problem. So that's exactly our problem. We need what we call these things outcome measures. So we need to have a way to measure the progression, whether it's the increase in spasticity, the decrease of how much you walk, the speed of moving your arms, legs, the speed of your speech, for example. We need way to measure that. And we're getting there because one of the ALS study, we used an app to record speech as patient read, for example, a passage from a book or describe a picture. And it's very interesting that the app was able to detect change in speech before the physician or the patient knows there is something, that there is a problem there. So we are having now, there are tools available that are better than the human brain that will help us really detect changes or measure things that may change without us knowing it and could be used as outcome measure. The problem with this, you have to validate those things. You have to use them on a big number of patients and understand how they behave before using them in a clinical trial or a research study, for example. But we're getting there. Things really have been changing. The movement also, I mean, the way you could write, there are apps, there is AI that could help interpret all these results that we get from apps and all these data that we have. So things are going to change, and I'm very hopeful that hopefully in the near future, we're going to see things moving in the right direction.
I have a follow-up question on that then.
Go ahead, sir.
There was, I saw something about a biomarker, because you're talking about objective versus subjective, and
Yes.
the ALS functional rating scale is very subjective. But I had seen something about a biomarker that they were getting close to one. Do you have any information on that?
Yeah, I don't necessarily have information directly, but in the study that we've been doing about the natural history of ALS, PLS, I'm sorry, we've been collecting blood. So we've been trying to work on that. We do know now that we have a biomarker called neurofilament that is available, but usually the neurofilament may not be elevated in PLS patient because the progression is so slow. So it's not, and neurofilament is not a very good biomarker because it's not specific to ALS or PLS. It just goes up when something affects the brain in general. So, but we're getting there. Having a biomarker would be the holy grail because you don't need to see change in the clinical. You don't have to worry about patient not progressing if you can see that biomarker. I mean, imagine you give somebody blood pressure medicine, you measure the blood pressure goes down, you know that your drug is working. A biomarker is something like that that you can measure that will change if the drug is helping, for example. So the research is ongoing to look at better biomarker in both PLS and ALS.
And do you feel, doctor, that may be something that Dr. Mitsumoto will be describing or talking about at the PLS International meeting in December?
Yes, that's a good question. I'm not sure how much of the results are available of the natural history. I know that it hasn't finished completely yet. So there's still, so it depends that if by December, they will have analyzed all the data or no. If they will, he probably will present something, but I don't know how far he's going to be presenting. But that information is really important. We need to see what they got. I mean, they were able to do that study over some period of time. It's one of the best study that has been done in PLS, like specific to PLS, not like piggybacking on other diseases. So the information is going to be very helpful.
That you're absolutely right. That information will be very helpful. Does anybody else have any other questions at this point?
Yes, please, if you don't mind, I'm not able to figure out how to raise my hand, but thank you, doctor, for being here. Just a couple of questions, if I may. First, you said that, of course, the primary aim of any new drug will be to stop the progression of the disease or to slow the progression, if I may say so, or the best would be to reverse it. Now, as far as I know, once nerve cells die, they cannot be regenerated. These are not like other cells in the body which can regenerate. So how is it possible to have a drug that might reverse the disease when once died nerve cells can't be reborn, if you like? And my second question is that I'm very new to this, and obviously it's shaken me up quite a bit. What is your experience with Keppra? I have heard that patients can benefit from Keppra, levetiracetam, normally used for epilepsy, but it can help patients with balance issues. I think my speech has started getting affected, and you may you may be able to make it whilst you hear me, but how does once affected, does speech tend to keep getting worse, or does it plateau, or the trajectory that a patient might take is absolutely not known because every patient is different? Could you please tell me a bit more about this?
Okay, so you asked me 3 questions. I'm going to try and answer them. So the first one, so the reversal could happen. So true, we do know there is brain plasticity and there is regeneration that happens. So it depends when we intervene. If we wait until that brain cell dies completely, there is no going back, okay? Well, if it's dead, it's dead. However, if we can intervene when the brain cell is sick but not dead, we may make it better. And that's how we may actually be able to see some reversal. It's interesting, there was a study, I don't know how much you guys know about it, in familial ALS due to SOD1 mutation. This is a form of ALS that is hereditary, and there is a drug for that called tofersen. And that drug actually showed that some patients who are taking the drug, the study for that drug was negative. However, we were able to see that there was a biomarker that was responded to the drug. And based on that finding, the FDA approved it as a accelerated approval. We have patients taking the drug now. And these patients, you would not expect an ALS patient to get better. We do have patients on that drug that are actually getting better. This defies everything that this is what we kind of hope, and this is what we are now seeing. So it is possible to reverse any kind of dysfunction if we have the right treatment and if we can intervene early enough before these motor neurons die. So that's the important thing. So we need to be hopeful. And the nice story we got from from this trial that was successful, the patient clinically were not able to show a difference initially at 6 months. But if you wait a year, you could see changes. If you wait 2 years, you can see even more changes. So sometimes it takes a longer time for the body to heal. And it's important, this drug would not have, we would have thought that this drug was negative if we didn't have that neurofilament going down and showing us that the drug is working. So I see that something like this could definitely happen in PLS as well. It could happen in other form. We're hoping that now the non-hereditary ALS will also respond like that if we have the right drug. Your second question about Capra. So in my experience, the response to Capra for my own patient, I have many patients who take Capra. It's different from patient to patient. So in some patient, maybe there is a response. In other, it doesn't do anything. There is no clinical trial. There is no study that shows gives Capra to patient and then actually follow what happens. All we have is patient reported kind of telling us that Capra helps them. So I can't really tell you in a very intelligent way if Capra is supposed to help patient or no. I think we need to do a good trial in this regard. We need to have a two group of patient, like any scientific experiment, give one patient the treatment and the other patient will be the control, and we'll see and measure and see what happens with. I mean, I respect the patient. I mean, they know their body more than me, but we have to have some objective finding to show is their spasticity changing, their exam changing, and we need to do that, not knowing who's taking what.
Well, when can we get started on that?
Yeah, it's a good idea. I will pitch it somewhere. We need to do a trial like that. We need funding for that. Capra is already a medication that is out there. So the pharmaceutical company, they use it for seizure. They will not be interested in running any trial. PLS is such a small number that even if all the PLS patient would take Capra, it's not going to change their bottom line. So these kind of experiment will be done through what we call an investigator-initiated study. And it will require outside funding. The pharmaceutical company will not fund it.
Well,
Sorry, doctor, is the drug for familial ALS you were talking about, is it terazocin that you were talking about?
Tofersen, it's called Tofersen. Qalsody.
Sorry, how do you spell that?
Tofersen, Tofersen.
Right, okay. But this is not available, commercially available, I mean.
It is commercially available, but it's only for the patient who have the specific SOD1 mutation. So it's only for a subset of patients.
Right. But it's not been tested in other sets anyway, so we don't
It won't
know.
work. It's a genetic therapy. So it's silencing that specific gene. So it wouldn't work for anybody else. But it's a good kind of a proof of concept. So if we have another gene that we want to turn it off, for example, we could do it the same way. And it's many other studies are being done using the same technology, even in patients who do not have genetic change, using other proteins.
Okay, thank you.
And there was a third question, and I forgot your third question. Oh, the heterogeneity. That is a big problem. Every single patient is different.
Yeah.
So I wish we have a way to see how patient could be similar. Why does patient X start in the leg when patient Y starts with the speech, for example? Why do even the progression that's supposed to be slow, some patient progress slower or faster than other? It is very different. And that's a big problem. And we need to make sure when we do any study that we're comparing orange to orange, not orange to apples. So it's very important. And I'm hoping that it's the biomarker that will help us understand and put patients that are the same in the same category.
Yeah. Thank you so much.
Absolutely, my pleasure.
We have Patrice here with his hand up and going to be asking a question. Patrice, go ahead.
Well, I was going to ask on behalf of Cynthia, who I see has her hand raised. So why don't we turn it over to Cynthia unless she needs some help?
That'd be great. Go ahead, Cynthia, please.
Thank you, Pat. Doctor, I have no idea. I started to say your name, and I don't know what to say.
That's okay. I go by Dr. Driss to make it easy on everybody. So you don't have to worry about the first part. Dr. Driss.
Well, you were discussing the brain's plasticity a while ago and mentioned that as long as intervention was done prior to the, I assume the cells dying or something, that the intervention might succeed. And my question is, intervene in what way? Are you talking about administering drugs, using physical therapy, or what?
No, I'm talking about drug administration. If we have a drug that can help, really, if we're doing a clinical trial and we have a drug that could help these motor neuron live longer, if we intervene before they're dead, we may be able to reverse things.
Is it possible, though, to get other motor neurons to assume the duties of the original ones?
No, I mean, we have our pool of upper motor neuron. They don't all die at once. They die over time, and that's the progression of the disease. So let's say, for example, if you have 5,000 upper motor neuron, just an example, and if because of the disease you lost 250, and it's better to intervene when you lost 250 than when you lost 4,000, right? Because
Correct.
that's basically what it is. So it's very important to be able to diagnose PLS early, not to have to wait 3, 4, 5 years before the diagnosis, before the symptoms are obvious.
Well,
And
what drugs
unfortunately,
would fulfill the duties of the intervention then? All I've
these,
heard of are gabapentin and
no,
baclofen.
these drugs will have to be discovered. We're talking
okay.
about in the future, yeah.
Okay, thank you.
You have to understand that the one we have now, gabapentin, baclofen, those are like taking an aspirin for a fever. Those are good to help the symptoms. They may not help the actual motor neuron, but they're good for the symptoms of the disease.
Well, I will ask one more thing then of a personal nature. I'm trying to retrain without knowing what I'm doing whatsoever. I want to emphasize I'm total ignorance here, but I'm trying to retrain other motor neurons in my brain to take over the duty so that I can practice walking or something. I'm in a wheelchair and I'm trying to walk with a rollator where I don't fall. Is this wise or not?
Well, I would recommend you work with a physical therapist. Exercises, stretching, all that is important. So working with a physical therapist will help you, will give you the tools that you need to kind of help train whatever part of your body that and I don't know what stage you are in, so it's very different for every person. That's why really working with a physical therapist is going to be important. They will assess you and they will tell you what is safe for you to do. Remember, one thing, you don't want to fall and you don't want to injure yourself. So that's why you need the help of a professional.
Thank you.
Anyone else have any other questions at this point? I see Teresa down here raising her hand. Unmute yourself, dear, and go ahead. There you go.
Okay. Can you hear me?
Yes, ma'am, we can. Go ahead, please.
Yeah. It's in response to the last question. I go swimming, and I have improved. When I used to swim when I was healthy, and I started going in the pool with my daughters, and I floated around like a goldfish. I didn't know what way was up. I was rolling around, and bit by bit, my brains learned how to swim as I used to. My leg stroke is about once every 4 to my breaststroke, but I lane swim now, and it gives me a sense of joy, and it strengthened me as well. So I do think you can learn new tricks by persevering and trying something, not pushing it though. That's all. And the other point I was just interested in the statistics, as there's so few PLS people. I'm in the UK, and as you say, there's been little interest. And when you're looking at statistics, why not include us globally? You've got Facebook action going on, and people are talking to one another. I'm sure you've got a responsive audience out there that would happily contribute statistically to your information. That's it, really.
Yes,
is
absolutely. I think you raised a very good point about making sure you go to your multidisciplinary clinic and you talk to the physical therapist, the occupational therapist there. There are things that could be done to make, like, you don't, I mean, of course, the holy grail is going to be the clinical trial and hopefully discovering new drugs that will help. But we have tools right now that could be used, and you have to take advantage of them. So definitely physical therapy, stretching, helping with the spasticity is very important. That's definitely, yeah, thank you for that. And water therapy, yeah, but you cannot just jump in the pool by yourself. You want to make sure there is help, people around you. You know what you need to do. As you said, you floated like a goldfish.
Yeah.
So you need help. Don't just go and
Yeah,
jump in a pool by yourself.
yeah, I had floats. I used to have big floats at first, but I've abandoned those now. But I use my rollator to approach the pool, and they have steps, and some of them have hoists, but there's very little support. You get support for 6 weeks or so with exercises, but they can't do it really. They can't give you permanent support. So you need to get out there
Yes.
and try and establish a safe routine.
That is very good
Absolutely.
advice, Teresa. That's exactly right. We have Jeff and then Cynthia, you're next. Go ahead, Jeff.
Oh, I haven't. Can I quickly respond to the second question? Any effort will be a global effort because it's such a small number that we do need to engage the global community for this. So definitely, we work with the UK. The meeting in December is going to be a global meeting with experts from all over the world. So yes.
Jeff, you got a comment or a question? Go ahead, sir.
Well, I guess I kind of want to beat that dead horse about doing stuff on your own. And, our bodies compensate. We see people with bad hips and bad knees and bad ankles, and their bodies compensate. And so, we're not going to be able to do everything because, the muscles might compensate some if we, especially if we're in physical therapy and we have some assistance to help us move. But, like Teresa's thing about swimming, I find that when I swim, I really careen off to one side because one side is weaker than the other. And so, eventually I'll probably get better with that. But I just learned that every now and again when I hit the barriers, well, then I need to kind of correct. But so I think there's some you can do certainly to keep active and keep moving. And to retrain some things, but I think there's certainly a limit to that. I mean, I'll never do some of the things that I used to do, but I can still do a variety of things. So, yeah, I encourage everybody to keep active. And the thing about PT, I think of the old thing about Jesus. If he feeds everybody it just feeds them for a day, but if he teaches them to fish and make bread, well, then they can feed themselves for their whole lives. And that's kind of what a PT does. A PT is about giving you the exercises, the things that you need to do to help yourself. So anyway, just kind of banging that drum a little bit louder.
We love that. Keep on banging, Jeff. That's exactly right. Cynthia, do you have a comment? Please go ahead. Unmute.
Yes, I'd like to ask Dr. Driss, what causes our body parts to float in the water? I get in the pool, and I've heard this comment from other people, all with PLS patients also. my right leg is the most severely affected, and as I'm lowered into the water on the lift, it starts, if I don't hold it down, it starts floating up. What is the cause of that?
I don't know. That's interesting. I've never heard about that. That's
Yeah.
really fascinating.
Yeah.
Well, Teresa mentioned rolling around
Yeah.
like a goldfish or something, and it caused me to think of it. But it happens every single time I get in the water, and I've heard other people say the same thing. So
I have
something
to
to
ask
look
my-
into.
Yeah, I have to ask my PT, honestly. I don't know.
Okay, well, thank you.
Patrice, you got a comment or a question? Go ahead, sir.
Yes, I guess for Dr. Driss and also Teresa, there was a second annual PLS Day in the UK on September 25th.
Yeah.
And there's supposed to be a recording of it. I don't. Richard Gibb, who attended our annual conference, was the one that forwarded the information to me. Norma, can you speak to that, or Doctor?
Yeah, Hank, can you speak to that?
Yeah, I attended it. It started early in the morning here. I only got the last part of the meeting. The way we are recording, but it was not available yet.
Yeah,
And they met for all day, so it's gonna be a long recording.
Okay, I
Yeah.
just
Yeah.
want to make sure Teresa was aware of that.
Yeah, I originally was going to go to it, and I had to cancel, and there was a lot of demand, so people needed tickets. So I went online live, so I watched it that way, and it was very interesting. It's the first symposium I've watched, was diagnosed May of last year after a few years of trying to find out what was the matter with me. And they did say it would be available. And so I persevere with it. I went and watched it on Zoom like we're doing. And it was worth the watch. There were a few nuggets in there, and also the comments were observations were really interesting to me, and it took me to looking at the Facebook groups which I didn't know about. So I've gone from feeling completely isolated to being aware that there's a whole community out there of you guys. So, um, uh, so keep looking. It'll be posted, I'm sure.
Yeah.
Or if you post on one of the Facebook groups and ask, they seem to be extremely helpful, and someone will put you right.
Well, and then we will also grab that link whenever that becomes available, and we'll share that on our website. We'll share that in an email to you, and then we'll also put that on our YouTube channel. So for those of you that are aware, we do have a spastic paraplegia website, and at the bottom of every page of that website is all of the social media platforms, including YouTube, and you will be able to capture that information on the YouTube channel. So we will get that information to you guys as soon as it is available, for sure. Jeff, do you have another comment or question? Please go ahead, sir.
Yeah, I was just going to try and answer Cynthia's question about the floating. Muscle weighs more than fat. So if the affected leg keeps floating, well, it just might be that there's not as much muscle in that, or you haven't fine-tuned that yet. And so that's why it's floating. And so that could very well be the reason.
There is actually very little muscle loss with PLS, at least in the beginning. It's a good thought. And compared to ALS, where the muscle actually atrophy, and PLS, the muscle is controlled by the lower motor neuron and usually stays kind of intact for a long period of time. I'm thinking about if it has to do anything with the actually the increased tone of that leg, that it stays up, doesn't fall down, may not be actually floating, but it's kind of up in the in the water, like higher, because you can't really push it down. But I'll ask my PT and see if they've seen it when they work with people in water, kind of water therapy or hydrotherapy, for example.
I'm sorry, Dr. Patrice, do you have a comment or a question? Go ahead.
I do. Doctor, what are your thoughts on different rates of degeneration
Yes,
within the PLS community?
is really different from patient to patient. I had a patient who I thought had PLS and looked like he had no involvement of the lower motor neuron, who was gone in 5 years, which is very, very fast for PLS. So he probably had ALS, not PLS. But again, I mean, you have every person is unique. You have good genes and you have bad genes, but that combination of good and bad is different in every person, and that may affect the progression of the disease, and may make it go faster or slower depending on your unique makeup. We do not know what causes ALS, sporadic ALS, but we know, and PLS, but we know there is probably an interaction between a subset of your genetic makeup and the environment you live in. And why did only the upper motor neuron degenerate in this case? We don't know that answer. Why do people develop? Why can't everybody have ALS, for example? Why is it one motor neuron is different than the other? We just don't know. We don't have an answer to that. And if we can understand what make PLS progress slowly, we may have answer to ALS. We can maybe change things that makes them look more like PLS than progress fast, for example. So we don't know. We're
Or
hoping that you
vice
guys,
versa.
or vice versa,
Right. Research in ALS
could help PLS. Yes,
Yeah.
exactly. It's going both ways.
Jeff, you have another comment? You're on mute.
Yeah, I have a question about the atrophy, the muscle atrophy, because I have kind of wondered about that. If the muscle is not being exercised because it's not getting the signal from our brain, muscles atrophy without use. So why don't our muscles atrophy? Why is that considered a difference between ALS and PLS?
So if you don't use your muscle, it will shrink. But the shrinkage, the way how fast it shrinks is different. In ALS, when the lower motor neuron is affected, there is actually degeneration. You could see the person, you could look at that muscle, and in 6 months, that muscle completely disappear. However, if the PLS patient doesn't move for years, then that's when you see that difference happens, right? So there isn't something making the muscle become small, like the lower motor neuron degeneration. We actually use that. When we put the needle of the EMG in that muscle, we see that the muscle is healthy, and that's important to diagnose PLS. But you are correct. If you don't move your muscle, it will eventually shrink, okay? But it will shrink in a different manner. It will all become small. It wouldn't twitch. It wouldn't like become kind of completely gone. So it's that atrophy is we call it disuse atrophy, which is a little bit different from what happens in the actual atrophy due to the lower motor neuron degeneration.
Okay, so theoretically, you could persist, make the muscles persist longer by trying to use it, whether you figure out a way to adapt something or you're getting help.
Correct. That's the importance of physical therapy. That's why physical therapy is important. And that's why stretching is important, because baclofen or with the medication by themselves don't help. The stretching help. And then the more range of motion you have, the more you can exercise that muscle. Whether you do that exercise actively, you're actually making the muscle work, or somebody is actually doing it passively. So it's important to work in your multidisciplinary, talk to your physician, go to your multidisciplinary clinic and make sure you get the rehabilitation you need.
Okay, thank you.
Dr. Driss, can I ask a question, please?
Please.
Have you come across any PLS patient who has converted into an ALS patient? I guess converted is not the right word, but you know what I mean.
Yes.
After 4 or 5 years.
You know, we do think of it as a spectrum. Many there are paper published about patients who have PLS, but after they pass away, when we look at their lower motor neuron, we do see a degeneration of the lower motor neuron. So it's a spectrum. In my experience, the patient that I have currently have PLS, they continue to have PLS. I haven't seen anybody develop the convert into ALS. But there are studies that show that people can convert. Most people convert within 4 years, but sometimes there are people who convert even years and years and years after. And anecdotally, we do know that we had a patient that converted after 38 years, for example, but that's kind of rare. Most patients, if they don't convert within that 4 years, usually they're out of the barn, like that it should be okay.
Right.
But it's not 100% guaranteed. We need to study more patients so we can have a better understanding. And we're hoping that we can have ways to tell who are the people who are going to convert without waiting years. It's very important. So.
And what subset are we talking about beyond 4 years conversion? What percentage of PLS patients, in your experience, I know you said it's rare, but what percentage wise or subset do you think might convert? Because obviously I'm still just 45. I'm scared that, few years down the line, this might turn into ALS. I've had my symptoms for nearly 4 or 5 years now and had an EMG just last month that was negative.
That's
but
good.
but that thought keeps looming large on my head.
Yes. No, I understand. It is really hard to answer that question. The further you are in your disease and you haven't converted, the better it is. So to go back, it's gonna be very hard to go back to you and say, okay, well, you crossed that 4-year mark, you're completely fine now, you don't have to worry. No, there is a worry, but it's better than 2 years ago, for example. You understand? I mean, it would have been difficult for me to tell you that. I will have way more optimism now, 4 years later, than, for example, 2 years within your disease.
I understand.
So the further you are, the better it is. And it's you just have to be hopeful. I don't have an exact number to you because we really don't know. Every single patient is different.
Yeah. Thank you.
Doctor, I have 3 people lined up, Cynthia, Kenneth, and then Linda Sue. I'll get to you, okay? So Cynthia, go ahead.
I have 2 questions. One was the PLS patient that you said converted to ALS. Did they have annual EMGs? And if so, did that not show up in the EMG? And the second question is, you had mentioned, I'm going to use the word autopsies. You did not say that, but that's what I'm saying. For lack of information, that's what I'm saying. Do you all, for study, is there a need for more bodies, or if so, could somebody please put the contact information or anything?
Yes, that's a very good question. Yeah, unfortunately, the other patient is an anecdote, right? He was fine, and then he wasn't fine anymore. Was there other things? I don't know. Yes, his 4-year EMG was normal, unfortunately. But sometimes things happen like that. But thankfully, it's not the norm. Now, yes, autopsies are very important. Studying the brain, it's very hard. We are all alive. We cannot get a good look at the brain, and we cannot go there and just get a biopsy of the brain. Unfortunately, our tools are getting better. The MRI is getting better, PET scans, there are tools, but we're still limited, and we can't really see much. So donating the brain and the spinal cord are important tools for discovery. And a lot of discovery that we made so far are based on the studying the brain and the spinal cord that the patient donate after they pass away. So it is very important, and thank you for bringing that up.
Could you please put the donation information so we would know who to contact or something?
I don't have donation information. I'm working on it. Northwestern used to have possibility to harvest brain and spinal cord after the patient passes. Currently, I don't. I'm working on that. There is the other option is the CDC registry. They will be able. There are other places. I can compile a list definitely,
Dr.
and
We have that list on our
Yeah.
website. I think
Yes.
Hank may be trying to grab that and put that out there. There are a number of brain banks that are across the United States. We have that information available on our website. The problem with that is that you've got to make sure that your family understands that as your last wishes so that it gets transferred very quickly upon your death, because that is very important. There's just a number of hours that has to take place
Yes.
once you have passed. So it's
So-
so very important that you make sure that your family understands that.
Would that fall under organ donation or into that category or what?
It is in that category, but it is a brain bank that is particular to what you are talking about. It's not necessarily for every person. It's for those people that understand that your brain or spinal cord needs to go to one of these types of research facilities that's associated with ALS, PLS, and HSP.
Okay.
So they got to know which facility. So you got to make those prior arrangements with that facility. And then you've got to make sure that your family understands that they have got to contact that facility, upon your death, so that that can all be taken care of, immediately, because it's like a number of hours that has to happen.
Would that be for brain only, or is there a need for like legs or?
No, brain and spinal cord. Usually that's what we
For
that
this.
most people get. Yeah. Some other places may need other things, but the most important thing is brain and spinal cord.
Okay, well, I will go to the SPF website, and then if Dr. Driss, if you can make whatever information you get in the future available, I'd appreciate it.
Hank has put that in the chat box.
Good deal.
Yeah, thank you
Thank
so
you,
much,
Hank.
Cynthia. Thank you, Cynthia, for bringing up that conversation, because that is very important. We have people asking us all the time for that information. Kenneth, you got a question, and then next I'm gonna call on Linda Sue, and then Kevin, you're up after that. Go ahead, Kenneth.
But before we move, make sure you talk to your physician about that. If this is something important to you, and if your physician has not bring it up, if they don't have a brain bank, just talk to them. That would be a good source of information as well.
When you say if they don't have a brain bank, since it's so time limited, are you talking about geographical area or what?
Yes, geographically.
Okay.
Kenneth, sir, go ahead.
Is there any relationship with concussions and PLS? I had 2 concussions from high school that I remember, and just curious if that's a possible cause.
It is being studied. We don't know exactly, but it is being studied. We do know that there is a condition called CTE, chronic traumatic encephalopathy, that sometimes may look like ALS or PLS, and that is caused by concussions. So it's definitely, the link is being studied. And we do know that certain athletes are more at risk. For example, Lou Gehrig had ALS, and we do know we haven't. These people tend to develop ALS more than PLS, so we're still that area is still being studied. Let me say that.
Good question. Linda Sue, you've been patiently waiting. Go ahead, dear.
Thank you. Can you hear me?
Yes, ma'am.
Okay. Doctor, have you ever had a patient and you knew on your, well, not first visit, but your second visit when you did the testing, knew they had PLS? Mine said on my second visit, then she sent me to a neuromuscular neurologist, and he confirmed it. I had 0 symptoms until I had my left hip replacement. Nothing before that. Nothing. and I started dragging that foot right after my surgery. And I guess my question also is, can trauma cause this PLS?
Yes. So the diagnosis of patient who have motor neuron disease is a clinical diagnosis. So with my expertise, when I see patient in my clinic, I don't need much. I know exactly what they have. Now, I sometimes cannot tell them, and I have to wait, that if they're within 1 year or 2 years of their symptoms, there is that risk of conversion, right? And I don't know when that's going to happen. So I don't want to tell them that. I don't want to give them false hope, and I don't want to raise their hopes, like, I mean, and not give them hope on the other hand, right? I
Well,
want to
they
be in the
both
middle.
they both said, well, the good news is you don't have ALS. Immediately they said that.
Yeah, I find it hard to say that for a patient who had symptoms only for 2 years, for example. I need a little bit more than that, maybe 3 to 4 years. So if I see somebody within the first year, the second year, maybe I point out the things that could be a good prognosis. But I will be guarded in my assessment, and I would say, let's wait and see what happens.
And is it common to have it? I just have it on my left side.
Mm-hmm. Yes. It always starts in one side, one arm, one leg. It's very asymmetric.
So it could go to the right.
It could, yes.
Possible. Okay.
Yeah, it is possible.
Okay.
Now, in my experience, it's not uncommon to have patients who tell me, I was fine until I had this surgery. I was fine until I had this illness. So maybe it's the stress, the mental stress and the body stress, that something that was supposed to happen makes it happen a little bit sooner. That's what we are thinking. We do not think that the surgery actually caused it. Otherwise, everybody who gets surgery gets something like that happen, right? But we do think that maybe that stress on the body was enough to push that person over the edge.
Well, is it unusual to be 70 years old when you get it?
No, it's not unusual.
It's unusual. Okay.
Yeah.
Okay.
It's less and less. We have patients who are 80s, in their 80s, who start
okay.
having this.
Okay.
The way I think of it is the further away you have it is because you probably had protective genes that protected you from developing it earlier. As we age, we lose kind of that protection a little bit, and these degenerative disease pop up, unfortunately.
Okay. So I shouldn't blame it on the surgery.
I don't think so, unfortunately.
Okay.
Thank you, Linda. I appreciate
Thank
your
you.
comment. Yeah. Mr. Kevin, go ahead, sir. You got a comment or a question? Unmute and join us.
Yes, I was just going to say regarding the studies post-mortem, the Bowser Laboratory at Barrow Neurological Institute has a number of studies going, and one of them is pre-mortem, where they're enrolling PLS and ALS patients, and they're growing motor neurons out of their stem cells and trying to understand what the difference is in degeneration. I happen to be on the board of directors for ALS Arizona with Dr. Bowser. And so when I enrolled, I was fortunate enough to get a full laboratory tour, and it was fascinating. I asked him on the postmortem what he thought about the theory that ALS, PLS, and maybe some of the other motor neuron diseases were a continuum or a spectrum as opposed to separate. He said there was no question based on what they found that the post-mortem PLS patients, they've removed brain, spinal cord, and muscle tissue from, every spinal cord had lower motor neuron death in the anterior horns for PLS. And he thinks that EMGs are a poor way to determine where you're at on the spectrum, but there's nothing better. And as far as they're still enrolling, I believe I will put the links up to the pages for the post-mortem study and the Bowser laboratory, but I carry a card that has a pager number for Barrow where when I pass, if somebody calls that number, Barrow will transport my body to the clinic. So it's not quite the same as a general brain bank. And I don't know if you can enroll from a distance. In other words, I enrolled for both studies. It took about half a day, and there is, I don't remember the exact number of pages, but I think it was at least a 20-page contract that I had to sign every page for the post-mortem study. And it may involve a trip to Phoenix if somebody wanted to participate. So I will pull those links and paste them in the chat.
That would be wonderful, Kevin. That is a lot of great information. And thank you so much for sharing that and knowing about that and being a part of that. So please share that in the chat. I did pick up the braintrustbio.com website, but that may not be the exact link that might be good for us to have. And we'll put that also on our website, Hank, whenever you get a chance to get that. And we'll share that with you guys as well.
I just want to clarify one thing to keep into your mind. Remember that most PLS patients, their last EMG is usually the one they do within 4 or 5 years of disease onset. So no PLS patient will continue to have EMGs all the way 20 years or 30 years later. So remember, the fact that we don't see it clinically does not necessarily, it's there. It's not that the EMG cannot detect it, it's just we stop having EMGs. And then when the patient passes away, it's many, 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 many years since that last EMG that happened. But I agree, it's more of a continuum now than just kind of separate diseases. There are, again, I mean, talk to the physician. There are many registry studies available that try to centralize these kind of brain donation. There is All ALS sponsored by the NIH. There is Target ALS. We are participating in Target ALS, that they may have kind of a subset that will take PLS also. So talk to your physician. They will be able to help you kind of find the right study or the right place for brain donation. You may not have to travel all the way to Arizona before you do that.
Just one quick comment. Target ALS is who is funding Dr. Bowser's postmortem study.
Yes, yes. We are funded by Target ALS too to do a study. We are looking for patients and we're looking for control. So if you have spouses, friends who say that they will do anything for you, just tell them, send them our way. It is important to enroll patients, but also it's important to enroll healthy controls so we can kind of develop those biomarkers.
Well, doctor, if you will send us some of that information that you're needing, then we will be glad to do e-blasts. We'll be glad to put that information out on our website and our social media platforms so that we can help you get those people.
Yep.
We definitely want to participate however we can to expand that awareness, because we think that is highly important. We can't really get our hands around all of the folks that have PLS. And while we can, and while there is this request and this need, we want to make sure that you've got people standing at the door to get in. And we want to do what we can to help that.
I will definitely check with our review board to make sure how can we advertise, and I will let you know. Thank you.
Good. Yeah, thank you very much. Patrice, you got a comment or question? Go ahead, dear. Cynthia, you're up after him.
Yes, Dr. Driss, you mentioned earlier, I think it was a drug for ALS that turns off a gene.
Mhm.
Is that a challenge for PLS? My understanding is we haven't really, in most cases, identified a gene for PLS.
Very good questions. You're right. But we could, it's true. In this, the drug that I talked about is for a specific familial form, so it's targeted gene. But we do know that are other genes that could be important, even though it's not genetic. So that technology is actually being used in ALS to turn off or to turn on other genes. And it's for sporadic ALS, like not the familial form. So if we know that there is a specific pathway, for example, that leads to degeneration, and we know what are the genes involved in that pathway, we can use the same technology that showed that it's effective and use it on genes that are not necessarily kind of causing the disease, but important for that specific motor neuron kind of health.
So your thoughts on identifying genes related to PLS degeneration?
Yes, the genes involved in the motor neuron degeneration, in the upper motor neuron degeneration, yes.
Okay.
Even if PLS is not genetic, even if we are not dealing, I mean, some form could be genetic, but if we're dealing with patients who do not have any abnormal genes, if we know how the motor neuron degenerate and we have certain genes that are suspect, we could use that same technology that we developed in the genetic forms to target those genes. It actually has been done in sporadic ALS already. It did not show an effect. There is a study that target ataxin 2. Ataxin 2 is a risk factor. There is certain kind of change in that gene that could increase the risk of ALS. So there was a study that Biogen sponsored to target that specific gene, even for in patient who did not have a change in that gene. Unfortunately, it didn't show that it was effective, but it is possible. You don't have to carry an abnormal gene or to have a genetic form to use genetic therapy.
Thank you.
Cynthia, go ahead, please.
I was under the impression that they conducted EMGs annually until death came. But you just mentioned a while ago that after about 4 years or so, you all discontinued that. I'd like to get some input on that and find out why.
I mean, that's what we do. We don't do EMGs every year for 30 years or whatever, like the lifespan is. It's impossible. We do them until the 4-year mark, and then we stop doing them unless clinically there is a reason to do them. So if after 4 years there is no evidence of lower motor neuron changes and clinically the patient does not really show any specific atrophy, there isn't really a reason to do them. These are painful tests. And already, I mean, I commend you, the patient who get one every year for like 4 or 5 years. So we try not to torture our patient more than they need to be tortured. Try not to do that.
Well, as a patient, I will say thank you.
Yeah, that's
Yeah.
kind of like good to know now that, you know, all these folks are on here. They need to know that they don't necessarily have to go get that test every year.
Do you recommend, is it a good idea to once every 5 years or something to have an
So
EMG
I will
done?
leave. Yes. No, I don't want to speak for your neurologist. I think every patient needs to speak to their neurologist, and for every patient, there is a schedule of EMG that needs to be done. But I'm telling you what I do in my practice. If a patient does not show any signs of lower motor neuron after 4 years, I stop there. I don't continue unless there is a reason for me to do it. But that's what I do. And patient can be, you know, maybe that 4-year EMG was like not normal, but not completely abnormal. So maybe that one needs to be repeated a year later. So again, unfortunately, every patient is different. So you need to take that into account. But if your 4th EMG, like the 4-year EMG is stone cold normal, there is really no reason to repeat.
Okay.
But talk to your neurologist. I'm not like, this is what I do with my own patients. So
Well, and as you said, doctor, every patient is different. And every neurologist is different.
Yeah.
Some neurologists, they're not as proactive in helping us to deal with the symptoms or to deal with, the circumstances of each and every one of our patients, because every patient is different. So, we've got to find a way in order that the neurologists, are hearing these things from the scientists. They're hearing these things so that our folks can get, some kind of treatment.
I hope that every single PLS patient is actually seeing an ALS specialist.
Wait, you froze. Wait just a second. You froze, doctor.
I'm sorry. I said, I hope that my connection is unstable. I hope that every PLS patient is being followed in a multidisciplinary ALS clinic by an ALS neurologist. Can you hear me? Did you hear me?
Yes.
Yes,
Okay.
we heard that very clear.
Okay. I hope that, like, if you are followed you to an ALS clinic, and the ALS neurologists know how to take care of the PLS patient because they're the ones seeing them.
So is that just as a show of hands for those that are on the screen? Are you seeing ALS neurologists? Everybody that is?
Yeah.
Okay,
Yeah.
good. Great. Very good.
So if you are in a multidisciplinary clinic, they know what they're doing. And we are trying to standardize the care across the ALS clinic. And most ALS physicians, they go to the same meeting, they hear the same science, they are doing like what needs to be done. So I think you guys are all in good hands.
Very good. Any other questions? Well, Dr. Driss, we really appreciate your time this afternoon. And I know I had promised you that we would basically be at about an hour, and we have far surpassed that.
Okay,
So
it was my pleasure.
Very much appreciate you. And we would love to invite you back and have a chance to talk with us again. We are going to launch over into some questions and do some support discussions here until, whatever time, at least between now and 5 o'clock. Central Time. If you'd like to stick around and join us and listen, that would be great. If you need to go, please feel free to go ahead and take leave. And we all want to put together our hands as best we can. And thank you so much for joining us today.
Yeah.
Thank you.
You are very welcome. It was my pleasure. I'm happy to come back. And I do need to take off. Hopefully I see you next time. Take care.
Thank you, Dr. Driss. Have a great afternoon. So for those of you that are going to stick around with us, we would really still like to take a few minutes, and we've got some questions here that Hank has popped up for us, and we would like for you to participate in our poll, in our survey, and give you guys a chance to have some input. We want you to, tell us where you're from, tell us, how many years, how long have you had PLS in years, what age did your first symptoms appear? We'd like to know, would you like to have more of these meetings? Would you like to have more of these discussions? And what kind of preferred speaker would you be interested in? And any other comments that you guys would like to give us, because we want to be here to help you. And while you're here, us here to help you, you're also here to help us. The conversations that I'm hearing and the conversations of the doctors and the answers, it just tells me more and more, we've got more work to do. And we need your help to help us to understand what is going on. And each one of us has our own walk and our own journey in this, but we can all learn from each other. So please participate in our survey. Please participate in any of the conversations that we've got going on. We would love for you to be a member of the foundation so that we can send you these e-blasts and let you know about these various talks and gatherings that we do. We've kind of named out, most of you probably know about TED Talks, technology education, those kind of talks up on that technological level. But what we've called it is SPF Talks. And we get together those subject matter experts like Dr. Driss, and we would be, happy to support these and be able to get us together, Teresa, and have conversations about things. And we would want all of you invited to all of those conversations. Does anybody have any other questions or anything else that you would like to talk about? Please.
Thank you very much, Norma and Hank. It was great. Appreciate it.
Well, our work isn't done, and our work is not going to be done until we find a cure. And one of the things that was the most enlightening conversation that I have heard in a long time is when she talked about reversal. Reversal can happen. And it's so important, Teresa, to stay moving, to keep moving. Don't stop moving. Whatever you need to do to keep yourself mobile and active, trying to get up, trying to move, keep your muscles going, keep your attitude going in a very positive way, and to try to relieve stress, right? Try to relieve stress as much as possible. If you've got a situation in your life and in your family and in your household that they don't understand what's going on, we hear that a lot. But we are here to have these conversations and to help us all to understand what's going on. Carol, go ahead, ma'am. You got a comment or a question? Unmute and join us.
Yes. As I said in my quiz, this is the first group discussion that I've ever participated in, and it was absolutely enlightening. And I want to say thank you. But I also want to ask something very important to me that was just mentioned. Does anyone have a quick answer to how to handle stress and anxiety of being punched with this disease? I mean, I find myself being so depressed and angry that my wings have been clipped and I'm no longer the real girl that I used to be. So I just was wondering if anybody has any words of encouragement. I've been dealing with this. I was started having symptoms in early 2022, but already by January of 23, I was diagnosed by an ALS physician with PLS. She was certain of that. So, I mean, I've heard a lot of different stories today, but stress and anxiety and depression, if anybody has any words of encouragement, I'm sorry I'm rambling and I'll stop now.
No, don't be sorry for the rambling, and don't be sorry for what you are experiencing, because you're dealing with what you're dealing with, and sometimes this is really hard to process. Before I get into my comments, Jeff, do you have a comment regarding what Carol just asked, or are you going to change the subject?
No, I'm telling Carol that time, that's the only thing. It's a punch in the gut, and it's an evolution. And yeah, at first you feel like, yeah, this really sucks. But eventually you kind of come to grips with it. And so take care of your mental health. If your provider didn't actually provide you some help for depression, then they should. I mean, you talk to them about that, because it is a depressing sort of thing. But it's taken an evolution. So words of encouragement, just well, I'm not sure that it'll get better, but you'll learn to deal with it and do things differently. So
thank you, Jeff.
Welcome.
And Cynthia, do you have comments regarding what Carol has mentioned, or do you want to change the subject?
Carol,
Okay.
what worked for me was just saying, instead of going, why me? I'm a nice person, why me? I just go, well, why not me? Bad things happen to some people, and this is what I have to deal with, and just learn how to deal with it.
Yeah. It's hard. And they say, well, thank goodness it's not ALS. Well, I thank God that it's not, but PLS is no fun ride either. So
Yeah. That's not a right comment for people to say, goodness, it's not this or it's not that. You know,
exactly.
until you've walked in this and you dealt with this and you understand what's going on, most people have no idea. They have no idea what a person with any kind of disability has to deal with on their journey. And for people to say that, they just don't know anything else better to say, you know?
Right.
And they're
Right.
trying to give some empathy, but that's still like the wrong thing to say. Teresa,
Reversal, yeah.
do you have a comment for Carol, Teresa?
Yes, I do. I just wanted to agree with Jeff. My experience has been exactly that I started showing signs in 2018. And as I said, I was diagnosed May 2023. But I had something called acceptance and commitment therapy as part of the support of the neuro team, and it was quite helpful. And I felt very bleak for some time, as you say, things that were important to me that I used to do, unable to do. But as time has passed, and I've realized that there is still new stuff I can do, and small triumphs like ramps and wheelchairs and good road laters, and you start feeling better about it. It doesn't go away, but it is not so bleak. You can live with it. So I wanted to agree with Jeff that you may get through this bad patch, but find out some support, what is out there, and there should be stuff for you.
Thank you, Teresa.
That's absolutely right. You know, I mean, there are so many more things that you are yet to do in your life. So don't allow yourself to let your brain give you that to stall you from what is grand and great and what is expected of you in your life, you know. And if you don't have that support group around you and your family and friends, then I'll give you my phone number and you can call me. Okay. And we'll have some girl talk. Okay. I mean,
Sounds good.
I wanted you guys to know too that just this last week, Wednesday night, we had a ladies talk. We did an SPF talk just like this, where we just had all the ladies have a conversation. We did a poll and said, here are 5 subjects. This is one of you guys pick. All of y'all pick which one of these things do you want to talk about tonight? And then we do that. We have those conversations so that everybody has a chance to, have themselves heard and have the support of all these ladies and guys. We'll do the guys eventually, but you have this opportunity to share with other people like you that are living with these things. And what are the tricks or the hacks or the tips? How can you help yourselves get through these days, that are ahead? And we've got a lot of days left in our lives. So don't give up on anything yet, because when I heard her say reversal, there's opportunity there for all of us. Patrice, do you have a comment that you'd like to make to Carol?
Yeah, I just think finding other people like you, like us. And, I think we probably all felt this. Well, not all of us, but many, especially when it takes so long to get diagnosed and then finally, and then finally you meet other people like you. And, certainly the SPF Foundation has been great. I don't know about your mobility, but we went to a conference a few years ago, and we still continue with that group. when we see each other at conferences or just reaching out to one another and checking how we're doing. So I guess this is our support group. We're one of them. So
Thank
anyway,
you. Thank
Yeah.
you. I have found on Facebook not only the SPF Foundation, but there's a chat group called PLS Worldwide. And that's actually how I got connected to you guys. So it is wonderful to, they say this is a rare disease, but there's so many people that have the same symptoms, that talk the same way,
Right.
that have lost their ability to speak, that have the same toe ache, have the same this, you know,
Right.
take the same medicines. It's wonderful. And that's why I said it in my comments today. This was the first time I reached out to a group in person on a platform such as this, and I'm grateful for each and every one of you for everything that I learned today. Thank you again.
Well, thank you, Carol. You're like our poster child for a commercial. You know, I mean, that's what we're really all here for, you know? I mean, really, seriously. And we've got to find ways that we can be outreaching and talking about these things, because we're all dealing with something, you know. And I have to wonder too, and I hate to say this, but is some of what we're feeling is the fact that we're aging.
Yeah.
So we're not only dealing with our health issues, you know, some people are having heart problems in addition to PLS. Some of us are having, you know, blood pressure issues in addition to PLS. But in addition to all of that, we're all aging.
Yeah.
And the natural body of aging, you know, they don't really teach you all this stuff when you're going through life and you're living, you know, living it up as a teenager or as a 20 adult, or, you know, or a 30-year-old, you know. You don't think about someday these things are going to kind of build up and they're going to compound on top of me. And little do you know that these things are happening, but it's all a part of the process. You know, we're all on this journey, and having the understanding of gratefulness of the things that you are grateful for. And then it just kind of takes some of that weight off of you, you know, having those good vibes, you know. I mean, from the foundation of the world, your life was planned, right?
Yeah.
And so we're trying to discover, because, you know, we might not have known each other had we not had these moments together because of these diseases.
Yeah.
So let's find reasons that we can still cling together and be friends. And actually, I tell people all the time when we're on talks and Zooms that you guys are really all a part of our family. You know, we're all connected by something. What's connected us with this disease, right?
Right.
What caused that? Cynthia, do you have a comment or a question you'd like to ask or say?
I have a question. My greatest source of stress is not dealing with the symptoms of the actual disease itself, but with a diagnosis of exclusion. And I'd like to know if it's just me, or if it's everybody else has accepted the fact that PLS is the correct diagnosis, that that's what they have, and they're not happy but comfortable with that evaluation, because I'm not.
That's a very good question. And I think you would probably hear that from everyone, that they're not happy with the fact that it has to be, you know, an exclusionary test or something. You got to go through all this, you know, to get to that point. So, yeah, I think everybody would feel the same way.
Yeah. Yeah.
Right? Everybody, thumbs up. Yeah,
Yeah.
exactly. You know, so, and that's what we've got to do as an organized body, you know, however you want to organize, but as an organized body, we have got to be screaming, and the squeaky wheel gets the attention. And don't accept the fact that you're rare. Don't accept the fact that some are ultra rare. Don't accept that. You know, we're all a part of having a motor neuron disease. It doesn't matter if it's upper, lower, it's whatever it is. It's all a part of the whole. And we all need to be finding ways that we can shout out what is most important. And that is obviously finding a cure, finding the therapy or the medication or the brand new compound that has not yet been discovered. But we have got to find a way to let these researchers and these doctors understand what's happening to us. And that's what we've been trying to do. But we need you to help us by coming together as an organized group of people so that they see that you are who you are. And then when I put together the conference and I invite these physicians, whether they're MDs or PhDs, you know, I want them to see you. And we've been inviting them to come back a couple of 2 or 3 years now in a row so that they can see this whole group of attendees and they can see the progression from whether it's a little child, you know, running around with one of those little rollators or whether it's an older person, right? They can see it in all of its progression. And I think that's what's really important because some of these scientists, they don't see patients. They only see us as a lab proposal, a lab report, but they've got to understand it from the perspective of what a clinician or an MD sees. And we've got to get them to better communicate and putting you into the center of that communication. Cynthia,
Well, how do we accomplish that? Because it seems like being a rare disease that there's no money in it for these researchers and all. So how do we accomplish that? Hey, take us seriously. We need help. We're legitimate.
That is really good question. And I really appreciate that. And that's what we have at the foundation has been trying to do is to get our hands wrapped around the number of people that have PLS. And we have very few people in our database. I think there's not near enough people in our database that actually are fighting for the life of what they're dealing with PLS and trying to get that around there and say to the doctors that we have X number of people, what is going on? And then what we do is we raise money and then we request proposals from doctors so that they can study the PLS. But unfortunately, there's not that many doctors that are actually providing us with proposals. So we're constantly trying to reach out there to those scientists that want to micro study just PLS. And luckily, in the last several years, we have received several more proposals. So let me invite you to be a part of the foundation by joining free the foundation. We won't sell your information. We won't give your information away to anybody. But if a doctor calls us or emails or communicates with us and says, we need to know how many PLS patients you have in Arizona, we're going to be able to provide a list. We'll send you the email and say, Dr. So-and-so, if you're located in Arizona or Washington or Florida or UK or wherever it is, they are asking for you to come in and do this blood and tissue test. They are asking for you to come in and do this type of work. That way you have an opportunity. I know one of the things that Dr. Mitsumoto had asked for is people that could be a part of his natural history study. And he didn't even get enough patients originally to go through all that process. So that's why we need to be communicating with you and you need to be communicating with us so that we understand who needs to have that outreach.
Well, originally he had such criteria that you had to meet everything, and there was something that I didn't meet, so I was unable to participate in that. And I understand that they might have relaxed those, but it's been so long I've forgotten. But
yeah, really and truly, Cynthia, what he should have been doing, I'm not trying to bash anybody, don't get me wrong, okay? But he should have been reaching back to you and saying, hey, let me go ahead and get at least enough information about who you are and what you're dealing with and all the basics. So I know one of the things that we've been trying to work on is what we've called a Centers of Excellence Research Network, which will be including PLS, anything spastic paraplegia. And so they're going to be putting these locations all across the United States so that when you go in, you're going to be able to have certain tests, certain biomarkers, so that you don't have to go through all these other kinds of what I call copay drains.
And that's on the that information is on the HSP website now?
Yeah, SPF, it's sp-foundation.org.
I didn't mean HSP. I'm sorry, I misspoke.
No, that's okay.
It seems like that is the emphasis from the SP Foundation, but
But it's
but I
not.
didn't mean to say that.
Yeah, but it's not the emphasis. It is equally as important to us, HSP and PLS. That's why I have hashtag. If you just go to your Google, open up a new browser and put in hashtag. You know, it's that little thing above number 3. Hashtag the letters HSPAND then you will find everything coming together that we always want to talk about, we always want to share. So you can find it on Instagram, you can find it on any of those social media platforms, and it's equally as important to us at the foundation.
Thanks.
Yeah, absolutely. Thank you all. Thank you all for all the work that you guys are doing to just meet your daily lives. That's important. That is so important. And don't give up on what's happening, but continue to bring forth to us all of the things that you're dealing with. When you get a chance to have a conversation with us, or you get a chance to join one of our talks or one of our Zooms, please do so, because I think it's really important for all of us to understand each and every one of our journey. I mean, here's the thing, Cynthia, if we have a meeting, a Zoom, probably 90% of the little thumbnails, right, that we're looking at, the windows, 90% of those people are HSP. So I'm always going, wait a minute, where's my PLS people? Where, why didn't they come to this meeting today? Because it's all the same kind of motor neuron diseases. It's all the same pathways. It's only when it gets into that motor neuron does it actually then micro in what's happening to your particular body. But we're all a part of that motor neuron family. So
thank you, Norma.
Join us everywhere. Join us anywhere that you feel comfortable sharing your story. We would love to invite all of you to be a part of any podcasts. If you would like to send us your story, we want to put that on our Spotify channel. And that way, your comments, your story, your journey might be the most uplifting support that somebody else might need to hear that day.
Norma, what you were saying earlier, you said a couple of times, but we give all these names to things, ALS and HSP and PLS. And I keep joking that it's all BSH, bad stuff is happening. So, the end result is the same. So, yeah, I don't think that we need to be contributing to the whole, well, I'm a zebra, and that's what the medical society thinks of us.
Yeah.
And, this is tiny, but, they need to focus on what is happening with HSP. It's the same thing, but, they know there's a hereditary cause, but it's sounding more and more from the talks with my neurologist and other people that, there's an epigenetic thing going on here, meaning that there is a gene inside of us, and it all may be different, but maybe we just drank the water at the wrong place sometime in our lives, and that turned that gene on. And well, okay, so
yeah, it could be. Maybe it's somebody got some kind of mold. Maybe it was a mold inclusion. Maybe it was some other. She mentioned environmental, right? There could be something else that triggered that to happen and to go ahead and grow that, in your particular body at that moment. You're right. Yeah,
So,
I tell people all the time, Jeff, that the HSP people, because when you listen to them talk, they've got, we've got almost 100 different kinds of SPG, spastic gene mutations. So each one of them are saying, well, what gene are you? Oh, I'm 7, I'm 11, I'm 15, I'm 50, I'm da 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 da, all of those numbers, and they are constantly in their minds trying to subdivide to even into a more micro, ultra rare category. And I keep trying to tell them constantly, you've got a motor neuron disease. Stop trying to subdivide yourself, because then why would a gene therapy company be interested when there's only 10 patients in the United States? But chances are there's more than 10. That's just like PLS. She mentioned way early on, she thought maybe there was like 600. And I think we thought that there's at least 3,000 people in the United States that has PLS. I bet there's more than that. So, it's all a part of the same family of motor neuron diseases, and finding that group of like-minded people that you can communicate with and that you can have some, relief of understanding that they're dealing with these issues just like you are. And what's your trick or what's your hack or how did you deal with that? I think those things become very important. One of the things
Right.
that we're also trying to work on is we've created a subcommittee of our research committee where we've got patient-led citizen scientists, people that are really studying about themselves and about the medical science that's coming out and all that information that's kind of like sometimes over your head and causes your eyes to glass over, that information can be found on our website. But at the same time, we're trying to get our citizens, our patient-led group, to think through what is it that we're seeing, what studies have been done these past 20 years, and where's the gap? Somebody has not figured out the gap, and let's research all of this information that we know. Let's create an AI study that says, here's what we've got, where's the gap, what's missing in these components. And that's the kind of thing that we're beginning to see what we can do to work in those areas. But I'd like to invite any of you that are interested into being a part of the foundation. We won't blow you out with emails, but we'll give you emails that tells you about upcoming meetings, upcoming events. The main goal of the foundation is to raise money for medical research. So we're doing these proposals to these doctors so that they can study what's happening. So if you know of any research scientists and they're not on our list, we want their information so that we can send them the request for proposals, so that we can send them the information that they can maybe apply for a grant. And what we're also looking at is the possibility of looking at gene therapy companies that might be available to build the compound. So what we need to be hearing is some of the stuff that Dr. Driss is saying, well, we don't know about that yet. Well, we don't know about that yet. Well, there's surely a scientist out there that might be interested in getting a grant from the foundation that can find out about that. And that's what we want to do, is continue to keep those doors open. Now, anybody else have any other comments before we say goodbye? There's a couple of things I want to tell you. Hank has compiled all of the information in the questions, and then we'll get all that information out to you guys. Anything else that you guys have a question about, please reach out to us and we'll be glad to find somebody to help us answer those questions. If you guys are all agreeable and it does look like perhaps maybe there were an overwhelming yes, would you prefer to have a speaker? You want somebody to come on and do some more of these meetings? 100% said yes. So let's do that. Let's figure out who would be the next best speaker that can help us. I would also like to invite you to look at the YouTube channel. We did have a couple of a speaker twice that talked about mental health and the things that you're dealing with a rare disease. So I would love to invite you to go to our YouTube channel, click that subscribe button. So when we put stuff up, then you guys would be able to have that information available. And you can just basically listen to it like it's a podcast, but you would have that information available. But I think also coming up, Hank, if I'm not mistaken, I got an email that Dr. Fink is going to have his Zoom meeting on October the 1st at 5 p.m. Central, 6 p.m. Eastern. So don't forget to put that on your calendar. And anything else, departing words, Hank, do you have anything else you need to say, or did I overlook anything? You're on mute. You're on mute. I can see you're talking, but you can't be heard. There you go.
That's all right. I'm losing my voice anyway.
That's okay. I guess we got everything. Everybody good?
How do we get on Dr. Fink's Zoom meeting? Can you post the link for that?
Yes. Again, let me tell you, if you'll go to our website, you will see that information that will get you that password code, if you will.
Okay.
but we will get that information to you and Hank can send that to you in an email.
Good deal.
So-
Thank you.
Yeah, so remember to go over and save the chat and then pop up where it says show in the folder. And you guys would be able to grab all of those links and all that information that's over there.
What is your YouTube channel, Norma?
Spastic Paraplegia Foundation. Do you
Got
see
it.
the chat box?
Well, I haven't been on Zoom for a long time.
That's okay. Let me tell you what to do.
I'm trying to navigate here. I see, yeah.
Do you see it at the bottom?
Yeah, I do.
That-
Yeah.
Okay, then just click on that YouTube channel there that Hank added, and then it will pop it out into a box on your tablet or computer or whatever. Then you're going to be able to go over there and grab that.
Okay, and
But let me tell you again though, Carol, at the bottom of our website, sp-foundation.org,
gotcha.
at the very bottom of every page, you'll see all those little icons lined up across there, and you'll see the YouTube icon.
Okay,
You'll
yeah.
see all of the platforms of social media. I even have a Pinterest that I put on there so that we can do the conference and I can tell people about things that are happening when those things are going on. So, you know, please feel free to grab those, reach out. If you have some changes or additions that you'd like for us to make, we'd love to do that.
Wonderful. Thank you also very much.
You're welcome. You're very welcome so very much. Okay. Well, you guys have a great Saturday afternoon. I think it's Saturday. And and if you want to join us in the future, just check your emails and we will have some more of these Zooms whenever we get the next speaker lined up.
Okay. Thank you.
Thank you very much. Thank you very
Bye.
much. Guys,
Bye.
be safe.